It is with great pleasure that I welcome my fellow regent and friend, Dr. Kenneth Sharp. Dr. Sharp is professor and vice chair of surgery at Vanderbilt University Medical Center. Welcome, Dr. Sharp.
Thank you, Steve. I'm happy to be here.
Thanks. Happy to have you. I've been very impressed with the incredible work that you've done over the last many months with our communications group, and wanted to talk to you a little bit about how what you do came to be. So perhaps you could tell our viewers and listeners a little bit about how this effort was initiated.
In mid-March, as the pandemic was becoming evident, Dave Hoyt and Pat Turner put out a Friday afternoon all-fellows email about how to make a transition to avoiding non-essential surgery. The regents and officers felt like we needed to be involved with this, and so we had a Sunday evening call, and we then developed the COVID communications team very quickly. So we met on, I believe, Tuesday, and by Friday, after meeting twice a day, we had a bulletin that was out with information for the fellows regarding COVID. I volunteered for the job of sort of monitoring what was going on with promising therapeutics, particularly pharmaceuticals. So I started scouring the literature pretty intensely from that point on, and that's where I've come to do some things I've never thought I would ever do, which is become an expert on vaccines and mRNA and on the pharmacokinetics of hydroxychloroquine, et cetera. So I've learned a lot over the last few months.
I've been very impressed by your contributions, not only in the ACS COVID-19 bulletins, but in ACS Bulletin Brief, and but also just in our calls, hearing the incredible amount of literature which you've read and how you do understand all of these different facets. So you, as far as I can tell, have read more non-surgical COVID-19 related issues than any surgeon I know by a long shot. And therefore, I'd like to take advantage of some of our time, ask you to talk about some of the best and worst that you've come across in your readings.
So let me just start by saying there's been a tsunami of literature on COVID. I have barely scraped the surface on this. There was a recent editorial in JAMA a few weeks ago. JAMA normally receives 4,000 manuscripts between January 1st and June 1st of every year. This year they've received 11,000 manuscripts, and virtually all of the excess is COVID related. And I saw another figure not long ago that said there have been 35,000 manuscripts about SARS-CoV-2 or COVID over the past 6 months. So the volume of material has been extraordinary. When it comes to what I think things have gone very well and some things I thought have not gone very well, I'd first like to say I think that we've had some pretty bad publications. And rather than call people frauds or anything like that, I think that 99% of what we see are really intense effort by physicians to get whatever little bit of knowledge they have developed out to other physicians. And so I think the intense desire to improve patient care and disseminate bits of knowledge people have accumulated has resulted in just an unbelievable plethora of poorly controlled, poorly designed anecdotal studies. And I think that probably the flag bearer for that is the hydroxychloroquine and azithromycin controversy that's been raging for 6 months. The problem with those, and I figured this out pretty quickly just by reading a half a dozen articles, is that there is some evidence that hydroxychloroquine and maybe even azithromycin have some antiviral properties in a test tube, but they're not really showing that up in people. And so the early studies, and many of the ones that got the most press, were from Didier Raoult, an infectious disease physician in Marseille, France, where he publicized several very small, not only uncontrolled, but probably self-selected patient groups, showing that hydroxychloroquine did seem to improve viral clearance in patients with COVID-19. Those articles got enormous publicity, but frankly, never have panned out. Unfortunately, the next step is that there then were dozens of reports of larger series of patients treated with hydroxychloroquine, chloroquine, or azithromycin that didn't show any advantage. The problem was, again, they were uncontrolled and or poorly controlled studies. So I think we have come to the conclusion now that there's not been any demonstrated advantage to treating patients with hydroxychloroquine or azithromycin in thousands of patients. But honestly, the best control studies are probably yet to be done. I think that's probably been one of the worst problems that we've had with the literature in this COVID era.
Thank you. A similar surge of papers has also hit other journals. I know that I've heard from some other journal editors, and we've seen for our journal for surgery a tremendous increase in manuscript submission. And in this current issue in August, we've got the first cluster of articles related to COVID-19. So, you know, this is certainly a point, and I can easily believe 35,000. So let's go to the other end of the spectrum and see from this 35,000 papers, what's the best evidence out there now? What would you say from your extensive readings would constitute best practice for treatment in a minimally symptomatic patient, if any, and then in a severely ill patient?
Our studies are very limited. I think that the two conclusively good studies have shown that first, the publication from the National Institute of Allergy and Infectious Disease, the multi-center study of remdesivir, the antiviral drug, has shown a reduction in severity of the disease when used in moderate to severe cases. In the initial publication, they did not demonstrate a conclusive or statistically significant reduction in mortality. Now, my understanding is that further follow-up has been done on that cohort of patients, and that there is now a reduction in mortality in severe disease demonstrated with the use of remdesivir plus standard therapy. Those patients specifically did not get hydroxychloroquine. I think the second thing that we've had published that is now widely accepted is the use of steroids in patients with severe COVID disease, especially those with the acute respiratory distress syndrome. And I think there, the Oxford study showed that there's been a significant improvement in mortality when an anti-inflammatory is used in very severe cases, and reduction in mortality of up to 30% was shown. Now, there have been a number of other anti-inflammatory approaches tried with IL-6 inhibitors, other steroids besides dexamethasone, and I think we're seeing that in the cytokine storm, that some anti-inflammatory probably does help reduce severity and mortality. I want to credit the critical care community for what they've done in disseminating information on best practices in critical care of these patients. I think that the way they've used their societies, a listserv, and the communities has disseminated a lot of very good information. And I would say that the two areas where I think they've made major impact positively has been in the use of anticoagulants in patients with severe COVID disease, and then also the difference in the management of the ARDS that's associated with COVID disease compared to ARDS from sepsis or trauma. They've shown enormous differences in the way they treat those patients on a ventilator. So I think that the critical care community should be really congratulated on a widespread sharing of information that has probably saved a lot of lives. I think they've done a very, very good job.
Thank you. While we're talking about medical specialties or surgical specialties, you mentioned critical care. In your readings, have you come across information that would afford you the comfort to opine on two other areas? A, the risk of surgery in a COVID-positive patient, and B, whether or not pneumoperitoneum and minimally invasive procedures should be undertaken?
Good questions. I think that number one, the risk of surgery in patients who are COVID positive is very substantial for people having upper airway procedures. Clearly, the head and neck surgeons, any thoracic surgery involving the airway, obviously tracheostomy carries a much greater risk of dissemination of the disease, not only to the surgeon, but the other people in the room. So I think we've learned a lot of ways to use specific personal protective equipment on those areas. And I think surgeons actually were the ones who came up with a lot of creative idea about intubation hoods and intubation shields that have been very, very valuable, because I think I learned from you that the otolaryngologists in Italy were one of the most infected and affected populations of physicians in Italy during their pandemic. I think secondly, laparoscopy, I think, has shown to be safe. The theoretical concern about dissemination of viral particles in the exhaust from laparoscopic procedures has been just that. It's theoretical. I think people are trying to filter and to avoid, or straight to suction. They've tried to avoid the exhaust of potentially COVID material from the abdomen, but there's very little data that suggests there's very much viable virus in the exhaust from a laparoscopic procedure.
And lastly, if I could turn to the future and ask you to polish off your crystal ball based upon your exhaustive perusal of the literature, where do you think we stand for a vaccine?
Honestly and truly, I get my best information here from the Wall Street Journal and the New York Times. Because of the enormous financial implications of the development of a vaccine, our business journals cover this better than any other source. And so, as you're well aware, we now have some 20-odd prospective vaccines in development, probably 100 candidates in development, but we are very close to starting phase 3 investigations of an mRNA virus. And, they have put aside, what did I read the other day? $13 billion so that Johnson & Johnson and Moderna can develop 300 million doses of vaccine in the next 6 months. I think that's another interesting topic, in that many of the scientists working on the vaccine are capable of developing vaccines and validating their utility, but they have no way to commercially produce the hundreds of millions of doses that would be necessary. So I think we have 2 parallel efforts going on. One is in the investigation and development and verification of a vaccine efficacy, and the second part then is the production. But we're Johnson & Johnson and Moderna are starting phase 3 trials of 30,000 patients. We've already passed the safety investigations in phase 1, and then phase 2, where they're looking at not only safety of the vaccine, but at does it raise an antibody. We've got those validated for a number of vaccines, and now we're just waiting to see, are they really going to be truly effective? So I think we will have a vaccine. Timing, oh, what the heck. Yes, I think we'll have a vaccine being distributed by the first of the year. So there you go. Here's speculation.
I'm glad you went out on a limb on that one. Good way to end the interview. Thanks again for your time and your expertise today, and certainly for the last several months. And I look forward to hearing more what you have to say in the coming months, because it's a lot easier to hear your Reader's Digest version of these articles than reading them all myself. Thank you. Dr. Sharp, on behalf of all of the tens of thousands of fellows and non-fellows around the world who've benefited from your readings, thank you very much. I look forward to continuing to be able to learn from you in the coming months. I thank you as well for your time today.
Well, thank you very much for having me. I feel like the college is making an incredibly intense effort to get information out to our fellows and to the general public. And so I think I'm very proud of what our COVID communications team has accomplished over the past 4 months. So I'm happy to be a part of this.